medicine in the United States. He completed his internal medicine residency from Louisiana State University in 1984 and completed his pulmonary critical care training here at the University of Miami in 1988. Prior to his faculty appointment in 2016, Dr. Chediak served as an associate professor, chief of sleep medicine, and the Sleep Fellowship Program Director at Mount Sinai, Miami Beach, until 2007 when he entered solo private practice, dedicated to the disorders of sleep. Dr. Chediak's publications include an original treatise focused on sleep-disordered breathing, technical assessments, and health policy salient to sleep medicine. As a sleep medicine thought leader and having served as president of Sleep Medicine's National Professional Society, Dr. Chediak has been a consistent force in shaping sleep healthcare policy at a local and national level. A strong proponent of processes that improve safety, create superior health outcomes, and enhance the value of healthcare, his leadership was instrumental in a health plan policy adoption of accreditation and specialty certification as preconditions of positive airway pressure treatment coverage for adults with obstructive sleep apnea. In addressing us today, Dr. Chediak brings over 3 decades of sleep healthcare expertise to the topic diagnosis and management of obstructive sleep apnea without polysomnography. Please join me in welcoming Dr. Alejandro Chediak.
Thank you. Let me start my personal timer here. Well, thank you very much. It's a pleasure to be here. I want to thank Dr. Weiss and the department for the invitation. It's always great to address colleagues, some of which trained me, some of which helped shape my professional career, and others of which I'm helping to shape their personal careers at the moment. This is a topic that is, I think, very timely. There's a lot of confusion about how to diagnose sleep apnea and manage it without necessarily using a sleep laboratory. So what I hope to do today is to give you an introduction to the way that we in sleep medicine look at the process of diagnosis and management of obstructive sleep apnea without necessarily having a sleep laboratory, and show you the pros and the cons. The first thing I wanted to point out is that when I turned 60, my internist told me that at my age I should have a bar in my shower. So I had one installed. Okay, so the objectives you already have as part of the flyer that Laura sent out to all of us, but just to reiterate them, I hope that by the end of this lecture you can appreciate the magnitude and the health burden of untreated obstructive sleep apnea, because that's really the underpinning behind the movement to diagnose and treat sleep apnea without necessarily having polysomnography. I hope you'll be able to triage cases for domiciliary diagnosis and management, and I hope you'll be able to assess objective adherence to positive airway pressure therapy. And here I'd like to pause for a minute just to remind everyone that positive airway pressure therapy is by far and away our preferred treatment for obstructive sleep apnea when treatment becomes necessary. I have no conflicts of interest to disclose, but I sure wish I did. Okay, so let's talk a little bit about the language we're going to use today when we discuss this topic. First, I think that I broke this down into respiratory measures, sleep measures, and outcome measures. So the respiratory measures of interest is the apnea-hypopnea index, and it's basically a frequency metric. It's the number of abnormal breathing events divided by some number of hours. In the laboratory, it's hours of sleep. At home, it's usually hours of recording. So there is a difference between those two. It's our best objective measure of vascular metabolic disease burden. So mild sleep apnea is defined by an apnea-hypopnea index of 5 to 14. In mild sleep apnea, we see symptoms but no cardiovascular sequela. And this is important because, as you'll see in the follow-up slides, the majority of the studies addressing this issue limit patient selection to those with high probability of moderate to severe obstructive sleep apnea. So those patients with mild sleep apnea can be symptomatic, but we have not demonstrated increased risk for arrhythmias, heart attacks, diabetes mellitus, etc. Moderate sleep apnea, we've seen some associations with hypertension, cerebrovascular accidents, and in females, dementia. In severe sleep apnea, which is an apnea-hypopnea index of 30 or greater, we've seen an increased risk for myocardial infarction, death, type 2 diabetes mellitus, arrhythmias, particularly atrial fibrillation, and PVCs. And then the other metric of interest in terms of outcomes is the time spent with oxyhemoglobin saturation below 90%. It turns out, based on the Sleep Heart Health study, if your oxyhemoglobin saturation is below 90% for 2.8% of your sleep time during polysomnography, then you are at increased risk for coronary events from untreated obstructive sleep apnea. In terms of the sleep metrics, our most objective test for sleepiness is the multiple sleep latency test. I won't go into the details, just to let you know that the faster you fall asleep, the sleepier you are. That's common sense. So if I keep you awake for 24 hours and I ask you to take a nap, you're going to fall asleep very quickly. And that's a measure of sleepiness. It doesn't tell us anything about why you're sleepy, just the fact that you are. We use, in this particular talk, and with these studies, the majority of the investigations have used subjective measures of sleepiness. The most common being the Epworth Sleepiness Scale. That's scored from 0 to 24. It's 8 questions, very easy to use. Generally speaking, if you score more than 10, you're sleepy. If you score 13 or more, it correlates well with multiple sleep latency testing objective measures of sleepiness. And then the other one you're going to see a lot in these studies is the FOSQ and the FOSQ-10. That takes a different approach to the question about sleepiness. It's really asking, how does your burden of sleep loss translate into an adverse functional outcome? So there, the lower the number, the greater the impairment. And then finally, the treatment, the language for the treatment of sleep apnea. So you hear a lot about CPAP, PAP, etc. Today we're going to really focus on 2 modalities, CPAP, which as you all know stands for continuous positive airway pressure, and APAP or AutoPAP. Now APAP is important for you to understand how it works, so that you, when we talk about the studies moving forward, you'll see why it's being used more and more in the out-of-center paradigms for the diagnosis and treatment of sleep apnea. APAP essentially analyzes every single breath you take while you're wearing the device. It's looking for a change in breathing that predicts upper airway instability, and it reacts by increasing the pressure output to stabilize that change. So it's trying to preempt you ever having an abnormal breathing event, which means that if it's effective, you don't need to adjust positive airway pressure therapy in the laboratory. You can simply prescribe APAP and accomplish the same outcome. Well, obstructive sleep apnea does have adverse health consequences, and of course the hardest endpoint of any disease is death. So this is a study from the Wisconsin cohort led by Terry Young and others, 18-year follow-up looking at mortality based on apnea-hypopnea index. It turns out that if you have severe obstructive sleep apnea, as you can see on the slide, defined by an AHI of 30 or more, then your all-cause death hazard ratio is 3. If you exclude the patients who were treated with CPAP in this cohort, the hazard ratio increases to 3.8. And the primary mode of death is cardiovascular, as you can see by a hazard ratio of 5.2. The conclusion of this is that obstructive sleep apnea untreated, when it's severe, increases mortality risk. How about treating it? Does treating it make a difference? This is a study now from Spain by Marin and co-workers, looking at about 1,600 men with obstructive sleep apnea of various degrees. The top panel, which is a little fuzzy, I suspect, on the horizontal axis you see years or weeks, of months of treatment. On the vertical axis, you see cumulative incidence of events. The top panel, panel A, is fatal events. The bottom panel is non-fatal cardiovascular events. The red represents severe untreated obstructive sleep apnea, and I think it's clear for everyone in the room there's a separation in severe untreated obstructive sleep apnea from all of the other curves that are plotted, both in terms of fatal and non-fatal cardiovascular events. Importantly, the blue is severe obstructive sleep apnea treated with CPAP, so that this appeared to be a treatment advantage. Obstructive sleep apnea is prevalent. If you define it solely as an apnea-hypopnea index of 5 or more, then 34% of our men and 17% of our women are afflicted with obstructive sleep apnea. If you look at moderate to severe sleep apnea, defined as an apnea-hypopnea index of 15 or greater, then in younger people, 30 to 49 years of age, the incidence in men is 10 and in women 3%. And in people that are less young, 50 to 70 years of age, the incidence is 17% for men and 9% for women. This is a disorder that is more common than asthma, to put it in perspective. There's a terrific burden both in terms of cost and in terms of health of untreated obstructive sleep apnea. The Institute of Medicine in 2006 and other studies have shown that over 80% of patients with moderate to severe sleep apnea remain undiagnosed. There's estimated to be about $3.4 billion in additional medical care costs as a result of untreated obstructive sleep apnea. And using 1990 census, when people were thinner and the burden of sleep apnea would be expected to be less, it's estimated that 10 million Americans have untreated moderate to severe sleep apnea and 25 million have at least mild sleep apnea or more. From 1997 to the present, there's been a significant rise in the prevalence of obstructive sleep apnea. And this should not surprise any of us, because if you look at the obesity tables, they mirror the same effect. If you look at the type 2 diabetes tables, the same data, because they're all interconnected. And in subgroups, the prevalence is incredible. Truck drivers, commercial truck drivers. Now think about this. You have a gentleman or a lady out there driving a truck full of gasoline, a combustible fluid, and they have a 67% incidence of having significant obstructive sleep apnea, which could impair their ability to drive the vehicle safely. If you already have cardiovascular disease, your incidence of obstructive sleep apnea approaches 80%. So this is a common problem, and undiagnosed creates significant burden in cost and in health. Let's take a look at the claims numbers from the insurance agencies to see how much we're spending or how much we're diagnosing and reporting obstructive sleep apnea. So the Fair Health Group is an independent, nonprofit organization dedicated to transparency in care and cost, and they use primarily insurance information to derive this data. Their report in 2018 showed that there were 25 billion privately billed healthcare claims for obstructive sleep apnea, and that's an 850% increase over between 2014 to 2017. It doesn't matter if you're in the rural area or an urban area, the increase is the same. And this is a little calculation I did for fun. So this month, we have 2,702 American Academy of Sleep Medicine accredited sleep testing facilities in this country. The majority of them are about 4 beds on average. So let's almost double that. Let's assume we have 5,000 4-bed sleep labs in the country running 365 days a year, 100% occupancy. Then we can study 7.3 million people per year, when our estimated need is about 25 million back in 1990, and we have a rapidly expanding patient population. Essentially, we have an insufficient capacity to meet the population needs. This is the reason why out-of-center testing or diagnosing and treatment without polysomnography is important. It's not the cost. The cost is one value, and I'll go into the cost factors, but to me it's important because we have this huge healthcare burden that we're simply not capable of addressing with our current paradigm. So I hope I've convinced you of the following in a few slides. One, obstructive sleep apnea is a common medical disorder. Its prevalence is increasing. Untreated, it increases health risk. Identifying and treatment of sleep apnea is increasing, as I showed you with the Fair Health insurance data, but the paradigm of care we are using is insufficient to address the burden of obstructive sleep apnea, and we need a paradigm shift if we're going to meet our population healthcare needs. So let's talk a little bit about diagnosing obstructive sleep apnea without polysomnography. And I use this as an introductory slide because I think you all need to understand the difference between the equipment that we use in the laboratory and at home. So polysomnography is traditionally called type 1 studies. We record sleep, breathing, oximetry, movements, a whole host of physiologic systems with 16 or more biosensor sets. Type 2 sleep studies I'm not going to talk about because basically the same sensor set, but there's nobody watching you, and it's not being used. Type 3, which is the home sleep apnea test of choice, is an unattended recording where airflow, respiratory effort, heart rate, and oximetry are the only metrics. So sleep is not included in type 3. Type 4 studies are basically oximetry and heart rate. And I'll only touch a little bit on type 4 studies. Okay, so here's the only tracings I'm going to show you, I promise. So this is what a type 1 study looks like, right? So you have up here your EOGs, your chin EMG, your EEGs for sleep. You can see this is called a sleep spindle. You can see all this movement here. This is an arousal. Down here you have your respiratory signals. This is a signal which is pressure over time. So pressure is on the vertical axis, time is on the horizontal axis. You can see how this signal becomes deformed. This is thoracic movements, abdominal movements. On the following two leads, you can see how the thoracic contribution to breathing becomes deformed. This is indicating increased impedance to breathing. That leads to arousal from sleep and restoration of normal breathing. So this is what a type 1 recording is in the sleep laboratory. This is what we're accustomed to seeing. I'm going to now take this same recording, exact same page. I'm going to cut out all the sleep stuff and show you what a home sleep apnea test recording would look like. So this is a home sleep apnea test recording. This is what it would look like. So we see only respiratory signals: pressure, thoracic movement, abdominal movement, oximetry, and heart rate. Now I'm going to show you what a type 4 device is going to look like. Saturation and heart rate. You see nothing. So traditionally, type 4 devices lack the sensitivity and specificity to be widely applied. So oximetry generally is not used, and so I'll talk about them very little. And type 3 devices have become the home sleep apnea testing tools of choice because they're easy to apply to sensor sets. They're, as I'll show you later, they're reasonably representative, and they're relatively less expensive. So let's ask a few questions that make sense for this talk. First is, do type 3 HSAT devices provide apnea-hypopnea metrics that are equivalent to polysomnography? This is a study from 2004. It was adapted by the Agency for Healthcare Quality Research in 2007 when they did a technical assessment of home sleep apnea tools. And it shows you on the horizontal axis, laboratory-based polysomnography, and on the vertical axis, simultaneously recorded type 3 data, type 3 recording data. The line of identity is the dashed red line here. And as you can see that within certain ranges of sleep AHI, that the devices correlate pretty well. And not surprisingly, the other thing you should point out is that home sleep apnea testing frequency metrics underestimate laboratory metrics. And that makes perfect sense because there the denominator is monitoring time, not sleep time. And monitoring time has to be longer than sleep time. In 2011, the agency did another review. They looked at 29 studies in total, 22 of which they had reviewed in 2007. They re-reviewed an additional 7 studies through 2011. Most of them were simultaneous recordings to compare the accuracy of recording AHI with home sleep apnea testing type 3 devices versus full polysomnography. And here are your sensitivities and specificities for an apnea-hypopnea index cutoff level of 5, 15, and 30. And I think what you can see is that the specificity and sensitivity is pretty good. And as you get more severe in your sleep apnea, as you get closer to the 30 and higher, the test becomes more representative of what's recorded at the home. So to answer the question, do type 3 home sleep apnea testing devices provide apnea-hypopnea indices that are equivalent to polysomnography? The answer, I think, is yes, particularly at higher apnea-hypopnea levels. So if you have someone you suspect with severe sleep apnea, it's probably a better candidate for these types of diagnostic tests than others. Next question. Do paradigms without polysomnography produce equivalent clinical outcomes? And this is key, because if we diagnose it accurately, but you're not using your treatment because of the way in which we diagnosed you, then what's the point, right? At the end of the day, we want to produce better clinical outcomes, not a more accurate diagnostic tool. So to me, this is the part that's more important in terms of this assessment and this talk. The series of studies I'm going to show you, which go back from about 2011 to 2018, typically look at outcomes as follows: adherence to treatment therapy with PAP, relief of symptoms by some subjective questionnaire, economic data when available, and some looked at systemic blood pressure and a few other things. There are some common protocol elements to the studies I'm going to show you. populations are highly selected. They're selected to have moderate to severe obstructive sleep apnea. So it's not generalizable to the entire population. In general, they're managed by experienced sleep personnel. The more recent studies trained nurses and trained general practitioners to understand how these devices work and how to manage and handle positive airway pressure therapy. The original ones used sleep experts only. So they all have some experienced personnel. They're all been conducted in tertiary referral centers, so we don't have a real world look yet at what this might do if we decided to use out-of-center testing and treatment for sleep apnea. And they all focused the attention to moderate to severe obstructive sleep apnea. The first of these studies was published in 2011, and it was criticized because it was a VA trial and it's a highly special or highly selective patient population, but it still gives you a sense of how these treatments or how this paradigm might work. Essentially, they enrolled 296 patients, of which 260 had sleep apnea and 213 eventually went on to be randomized to receive CPAP therapy. All patients had a sleep clinic evaluation by an expert, and then were randomized to either have in-lab, what we call split-night polysomnography. If they had an apnea-hypopnea index that was 15 or greater, less than 15, they went on to clinic follow-up, no treatment. If they had a positive study for obstructive sleep apnea of moderate to severe degree, they had an in-lab titration, and then they were sent home with a CPAP device based on the in-lab adjustment. This is what's traditionally done in many facilities still even today. And they followed up in 3 months looking at CPAP adherence, functional outcomes of sleep, and medical care cost. The primary treatment outcome, this study was powered for the functional outcomes of sleep questionnaire, was not powered for CPAP adherence or medical care cost. If you were in the home arm, then you received a home sleep apnea test with the type 3 device, followed by home automatic positive airway pressure titration. Now, these automatic devices report to us what the average pressures are and what the most representative pressure might be. And you can take that data and translate it into a fixed CPAP pressure, and that's what they did. So they basically said, the automatic positive airway pressure device tells us that you need 9 centimeters of water pressure to control your sleep apnea, so we're just going to take this more expensive device away from you, give you a cheaper one that's going to produce only 9 centimeters. Right. In terms of the primary outcome measure, the functional outcomes of sleep questionnaire, there was no difference between the two groups. So they had a net improvement of about 2 units in the FOSQ. It was equal among the two groups at the end of the 3 months and at the 1 month point as well. In terms of treatment, CPAP adherence, which to me is an important outcome metric, they both did poorly. About 3.5 hours for the home group, about 3 hours for the in-laboratory group. There was a tendency towards better use in the home group than in the in-lab group, but it was not statistically significant. In 2006 and 2007, when I was still involved heavily on the board of the American Academy of Sleep Medicine, we wanted this question answered, so we commissioned a study and funded it to look at the differences between a home paradigm and a laboratory paradigm and what the outcomes would be. It was called the HOME-PAP study. It was published in 2012. The study objectives were to test the utility of a clinical pathway versus that used a sleep laboratory versus one that did not. And it was a randomized, open-label, parallel group, multi-center trial with 373 consecutive new referrals, of which were predicted to have moderate to severe obstructive sleep apnea before entering the trial. The interventions included a type 3 home sleep apnea test followed by 1 week of APAP. The data from the APAP was then used to switch the machine and put the patients on fixed CPAP. That was called the home arm, compared to an attended in-laboratory traditional arm, as I described earlier in the VA study. The primary measurements of interest were CPAP adherence, the time to treatment adherence at 1 and 3 months, the changes in the Epworth Sleepiness Scale, and the functional outcomes of sleep questionnaire. At 3 months, positive airway pressure treatment usage was 1 hour greater for the home group than for the laboratory group. So you achieved greater adherence with therapy with an out-of-center paradigm as opposed to a laboratory paradigm. If you define adherence as the percentage of nights the treatment was used for at least 4 hours, it was 13% higher in the home group than in the in-laboratory group. And if you look at acceptance of PAP therapy, the time to acceptance of PAP therapy, the titration pressures required, the effective titrations required to get to the endpoint, the time to treatment, the Epworth Sleepiness Scale score, and the other metrics mentioned, there was no significant difference between the two. In 2017, the Spanish group came up with a similar protocol. The difference here is that you have polysomnography at 6 months, which we didn't have in the home PAP study or in the VA study, and you have 24-hour blood pressure monitoring at the end of the study. They basically randomized the groups to a laboratory arm versus an arm out of the laboratory. And similarly, they used auto-titration devices to adjust CPAP in the out-of-laboratory paradigm. PAP improved all of the measures you see here, the Epworth Sleepiness Scale score, Functional Outcomes of Sleep Questionnaire, SF-36 physical, and a number of other subjective measures that are typically abnormal in patients with obstructive sleep apnea. The only thing it did not improve was the body weight, which we know that treating sleep apnea with CPAP generally does not improve body weight, contrary to common belief. And two, the SF-36 mental component of the study. It improved it equally, regardless of whether you were studied in the laboratory or at the home arm. At 6 months, the only difference on polysomnography was the patients who had gone through the polysomnography arm had more deep sleep. That's of questionable clinical value. But all the other metrics in terms of sleep, in terms of control of sleep apnea, in terms of hypoxemia, were equally controlled at 6 months study in the laboratory with full attended polysomnography. There was no significant difference in the 24-hour blood pressure monitoring between the two groups. This is a study, a multi-center trial done in Australia. Slightly different approach. It's kind of interesting. What they did is they took full night polysomnography, and then they kind of broke it up like I showed you in the tracings, and they gave some doctors the entire polysomnogram to look at. They gave other doctors only the respiratory tracings that are consistent with a type 3 device, and they gave yet another group only oximetry and heart rate. And they asked the questions with limited data, but the same patient and the same degree of recording, same recording night, how will that change the outcomes? Primary outcome being the functional outcomes of sleep questionnaire, and the secondary outcomes being a sleep apnea symptom questionnaire, the Epworth Sleepiness Scale, and of course, adherence to positive airway pressure therapy. So here I've tried to use some colors so that you and I kind of keep track of where this is going. So the red in TI is the polysomnography, a type 1 device. And what they found is if you use a type 4 device in purple versus a type 3 device in the blue, those are not inferior in terms of the outcomes to a full polysomnography as it pertains to the functional outcomes of sleep questionnaire, which is one of their primary endpoints. However, the type 4 device, which is oximetry and heart rate only, was inferior in terms of symptoms of sleepiness and sleep apnea symptom questionnaire, suggesting that perhaps the decision-making with a type 4 device is different than with a type 3 device and a type 1 device. If you look at utilization data, PAP adherence data, the PAP adherence data was similar whether you use polysomnography or a type 3 home sleep apnea test, but inferior if you had used a type 4 home sleep apnea test device. So this is the only part of today's lecture that I'm going to use to talk to you about the type 4 devices, as I mentioned earlier. The take-home message being oximetry and heart rate recordings by themselves are probably not sufficient to achieve the same outcomes as we're currently getting with polysomnography and with type 3 devices. So finally, do paradigms without polysomnography produce equivalent clinical outcomes? Well, I think the answer is that if you use a type 3 home sleep apnea device, yes, for symptom relief, and yes, for PAP use. In fact, you may actually achieve better positive airway pressure treatment adherence based on the data from the home PAP study and the data from the study conducted in Spain. Now, we still have the problem that these are highly selected patients, tertiary referral centers, managed by sleep experts. How about the expense? You'd expect them to be cheaper. In fact, a lot of the interest in this field originally was to reduce the cost of diagnosing sleep apnea by eliminating polysomnography. As I mentioned to you earlier, that's not my interest in the field, but it is an interest of this paradigm with out-of-center testing. So let's go to the home PAP study, the one that was paid for by the American Academy of Sleep Medicine. So in the home PAP study, the home arm was about 25% less than the laboratory arm. And this is probably the most representative study as it pertains to the United States, because all of the centers were in the United States. All of the costs were adjusted for 2011 Medicare costs based on the region. So there's probably about a 25% cost savings for a home arm as opposed to a laboratory arm for diagnosing and treating obstructive sleep apnea. In the study that was conducted in Spain, the average savings was about 416 euros per patient. And this is a study that was published just last year. It was conducted in Spain also. It looked at having a paradigm where the home testing was automatically reviewed rather than manually reviewed. The home testing was then analyzed automatically based on the clinical history automatically using a computer algorithm to decide who should be treated and who should not be treated, and then looked at patient outcomes. And what they found was that using a completely primary care-based, algorithm-driven protocol, the cost savings were between 424 to 621 euros per case, or they averaged about 520 euros per case. Again, showing some cost savings and outcomes that were, for the most part, similar to an in-laboratory paradigm. So, do paradigms without polysomnography cost less? I think the answer is yes. And if you really hone down the data, and I didn't want to bog you down in this degree of detail, but if you hone the data down, it's primarily due to the lower cost of testing, not necessarily due to repeat visits to the doctor or repeat adjustments, etc. So are there clinical circumstances that degrade the utility of home sleep apnea testing? Simply put, can we predict who should not have a home sleep apnea test? I think the answer is yes. Here's one study looking at apnea-hypopnea index from polysomnography versus a home sleep apnea test conducted simultaneously while attended in the sleep laboratory. And this is important to remember that apnea-hypopnea indexes do have night-to-night variability. And so if you're going to test the accuracy of a tool, it would be ideal to be able to simultaneously conduct the two measurements rather than to conduct them on separate nights. The downside is that you have a technician in the laboratory and not at home. And so the home sleep apnea testing tool gets a little bit of an advantage because the technician can intervene and replace sensors. And we know from other data that there's about a 25% overall data loss as a result of home sleep apnea testing. So this is in patients who have a pre-established diagnosis of moderate to severe obstructive sleep apnea, and I won't get into what the FEV value was, although I know my pulmonary cohorts here would like for me to say that. And it looked at what is the accuracy of, in moderate to severe COPD, of using a home sleep apnea test versus using polysomnography for establishing an AHI. And it turns out that there is a significant difference between the two. And even in the laboratory, there were significant recording failures for the home sleep apnea testing apparatus, mostly due to sensor movements and data loss based on sensor movements. Monitoring time is another important determinant of accuracy of home sleep apnea testing to produce an AHI that is representative. So in this study, the investigators basically took the studies and just cut down the number of minutes of the analysis to see how much false positive, how much false negative, and how much underestimation or overestimation of severity one would get if you had fewer minutes of recording. So all the way to the right is 420 minutes of recording time. All the way to the other end of the spectrum is only 1 hour of recording time. I think it's pretty clear to see if you look at the dark black bars here that the percentage of false negatives for OSA decreases or as you get more and more recording time, or increases as you get less and less recording time. So as a general rule, home sleep apnea testing that is under 300 minutes is considered inadequate for accurately excluding obstructive sleep apnea. We also believe that if you have a negative home sleep apnea test, you probably should have polysomnography, because a negative home sleep apnea test can be falsely negative. So there are conditions that degrade the quality and the utility of home sleep apnea testing. And I mentioned only one for the sake of time, but there are others, and I'll just summarize them at the end. Of the comorbid medical conditions that degrade home sleep apnea testing and can interfere with automatic positive airway pressure therapy adjustments, perhaps the best studied are moderate to severe pulmonary disease, neuromuscular disease, and congestive heart failure. Congestive heart failure patients have a much higher incidence of obstructive sleep apnea, but they also have a much higher incidence of central sleep apnea, and that confounds the recordings. The home sleep apnea testing has not been validated in patients who have primarily central sleep apnea or who have combined obstructive and central sleep apnea. In other sleep disorders, such as periodic limb movements of sleep, insomnia, narcolepsy, etc., home sleep apnea testing has no value. Now, in some of these, neither does polysomnography. There's no value for polysomnography in insomnia unless you think the insomnia is due to sleep apnea or periodic limb movements of sleep. Okay? And it's not indicated, home sleep apnea testing, regardless of what type you want to use, is simply not indicated for asymptomatic patients as a screening tool. So in summary, there are insufficient polysomnography resources to diagnose and treat all at-risk OSA patients. In selected populations, type 3 home sleep apnea testing devices provide respiratory indices comparable to that we obtain with polysomnography. Paradigms for moderate to severe obstructive sleep apnea diagnosis and positive airway pressure care without polysomnography can offer similar symptomatic outcomes in PAP adherence at lower cost. And evaluation without polysomnography is not indicated for certain populations. A negative home sleep apnea test in an at-risk case warrants polysomnography. Home sleep apnea testing paradigms are best guided by experienced clinician. This does not mean necessarily an experienced sleep physician. Don't tell Dr. Abreu I said that. But you do need to have training in the waveforms and in the management of automatic positive airway pressure therapy. And paradigms that do not require polysomnography offer us the opportunity to reach the number of patients that are currently undiagnosed and at risk for adverse health outcomes due to obstructive sleep apnea. Now, I'd like to close with a couple of cases. I think we have time for them, but before that, I just wanted you to get a little understanding about the way sleep doctors think. So we're an odd bunch of people because we actually believe that sleep is the most important behavioral state. It's far more important than being awake. So dozing off during my lecture is considered a compliment to my style of speaking. I thought that if I had time, and I do, that it'd be fun to throw in a couple of examples of how home sleep apnea testing may or may not be helpful and how APAP treatment might be used to manage patients with suspected obstructive sleep apnea. So this is actually a physician. At the time, he was a University of Miami faculty member who saw me when I was in private practice. He's a 55-year-old male with hypersomnia and disruptive snoring after a 50-pound weight increase. It sounds kind of like my history lately. He had an Epworth Sleepiness Scale score of 12, so that puts him in the sleepy range. He had 2 episodes of unintended dozing while driving. That puts him, to me, in the severely sleepy range. His body mass index was 37, his neck circumference was 17.5, and he had arterial hypertension as part of his medical history. I conducted home sleep apnea testing. It was technically adequate. He had an apnea-hypopnea index of 40 and spent 9% of the recording time with an SpO2 below 90%. So this puts him in the severe sleep apnea category, at risk for adverse cardiometabolic health outcomes without treatment. So I started treating him with APAP without laboratory testing. I allowed the machine to start at the minimum, allowed it to go to the maximum, and I picked my favorite mask, which is what I do for most of my patients. Since I'm a PAP user, I'm a masked man, as I like to say. I test all these things out, so I have my favorites, and I told him I recommended my favorite mask. I saw him at 6 weeks, and then I've seen him again over the years. At 6 weeks, there was no weight change. His Epworth Sleepiness Scale score had gone from 12, which is sleepy, to 4, which is normal. He was not snoring while wearing the device, so the household was happy. I've saved a lot of marriages in my career as a result of treating obstructive sleep apnea. His positive airway pressure treatment utilization mean was 6 hours and 39 minutes a night, and he used treatment for 4 hours or more on 80% of the opportunities during the sample of the 6 weeks. Residual sleep apnea, as recorded on the device, was 3.3, less than 5 being normal, less than 10 being acceptable. And he had similar data at 1 and at 2 years, and I lost him to follow-up when I came back to the university. I guess he didn't want to come back. So this is an example of home sleep apnea testing, followed by automatic positive airway pressure therapy, successfully diagnosing and treating sleep apnea. Yes, Elio? Intranasal mask means that it's pillows. Sometimes they're known as pillows. So I'll remember that and simplify for the next talk. Okay, so here's an example of a misleading home sleep apnea test. This is one of Dr. Abrou's patients. She's a 65-year-old female with a history of hypertension and renal cell carcinoma, a body mass index of 33 almost, a predictive of having moderate to severe sleep apnea based on a questionnaire called the Stop Bang questionnaire. On home sleep apnea testing, she had an apnea-hypopnea index of 4.7 per hour of sleep. But she spent 4% of her sleep time with an oxygen saturation below 90, so something doesn't jive up there. Right? So, as I mentioned earlier, in a high-risk patient, when you have a negative home sleep apnea test, you should bring them into the laboratory to test them, so that's what we did. The split night study showed posture-sensitive obstructive sleep apnea, 87 episodes of sleep apnea when the patient sleeps on her back, 22 when she's on her side. So that may have been one of the confounding factors that made the home sleep apnea test negative. The other possibility is that she didn't sleep very much when she was during the home sleep apnea test, because even if she had spent the whole time on her side, we should have gotten close to an apnea-hypopnea index of 22, not 4.7. We found that 6 centimeters of CPAP provided optimal control of sleep apnea during the split night polysomnogram. On 30-day follow-up, her CPAP use was 7.1 hours per day, and she was 97% 4-hour adherence. So having said that, I think I've finished just when I wanted to at about almost 12 minutes left before the end of the talk to give everybody time to go to their next appointments and also to ask me a few questions.
Thank you, Dr. Chediak, for very clear and informative grand rounds. Let me just start with a very practical question at first. How do we order for our patients home CPAP? Is there a requisition, special requisition? Is it on U-chart?
Yeah, I'm working with our U-chart gurus to create a prescription within U-chart because at the moment one does not exist. So what I was able to do to them the first year I was here was to create a basic prescription, but I haven't been able to work with them enough to tweak it to make it usable for everybody. What we do now in the sleep laboratory is essentially we have a printed form that we fill out manually. So it's very archaic at the moment. That's part of what needs to be automated for this system to work for us here in Miami.
Dr. Gardner.
Alex, impressive data that under optimal circumstances you can do remarkable good.
Agreed.
Population numbers that you started the talk with must have surely raised questions in our younger physicians here about how social determinants affect the ability to both diagnose and effectively treat this illness. Thinking about patients with inadequate access to healthcare, inadequate environments for treatment, and not likely getting even close to qualifying for in-center testing. Are there compromises, let's just be slightly irreverent, that we might consider for some of our patients who have symptomatic descriptions of awakening at night and severe snoring and somnolence during the day, where we might try therapy even without the comfort of the testing you described?
Yeah, that's a great question, and I have an answer for you based on science and also based on my own practice patterns in the past. So it's clear that not everyone can afford even to go through a home sleep apnea test. And the problem that we face as clinicians is not that we need the home sleep apnea test in some patients, because in some cases it's blatantly obvious that the patient has obstructive sleep apnea. The problem is that to get a third party, whatever third party you have in mind, to pay for it, you need to demonstrate objectively that the patients have obstructive sleep apnea. The health plans simply do not trust our opinion as clinicians. It's just that simple, bluntly put. But there is science showing that automatic positive airway pressure therapy in well-selected high-risk patients for moderate to severe sleep apnea can be applied, can control symptoms, and provide reasonable utilization outcomes similar to patients who are treated in laboratory or with a home sleep apnea test before receiving automatic therapy. So this is no testing. We give them an automatic positive airway pressure treatment apparatus, give them a mask, let the machine make the decisions. Utilization, subjective measures of sleepiness, subjective measures of well-being seem to improve similarly. There was one study, I think it was in 2010, by some of you might remember Conrad Bloch, who was one of our fellows at Mount Sinai. Went on. He's now faculty in Switzerland. He did almost that same study, but his angle was he was trying to diagnose sleep apnea based on the response to automatic positive airway pressure therapy, and found that he could reasonably diagnose it based on patients who experienced symptomatic benefit when he compared the outcome to polysomnography. To me, that's just a setup for the next level. The problem with the next level, meaning treatment without necessarily having an objective test, is getting people to pay for the treatment and getting our health plans to understand that it's going to be cost effective. And the problem we have, of course, is that health plans are not forward thinking. I learned this about 20 years ago when I sat down with Blue Cross and Blue Shield and told them how much money we could save if we diagnosed and treated all these patients with sleep apnea. And they basically told me, yeah, but in 2 years, 20 or 30% of our subscribers are going to go on to another health plan. I had that message reiterated to me when I was at the AMA meeting just yesterday and the day before. Essentially, health plans coming forward and saying that, yeah, you can do all these things preventatively, but our subscribers are going to move on to another health plan, so we don't care about health.
Another argument for single payer.
Agreed.
Dr. Matterson.
Mr. Weiss knows I'm going to ask about hypertension, of course. The difference between APAP and CPAP on a couple of your slides, if I read them correctly, favors APAP in terms of control of otherwise resistant hypertension or hypertension that puts out of control.
Yeah.
You didn't define it that way, but that's the way it looks.
It hasn't been studied in that format to compare the two. Most of what's been done is compared utilization of the two. Both can reduce blood pressure equally, as I showed you in the one study that had a 24-hour blood pressure monitoring. So both the CPAP arm and the APAP arm both controlled blood pressure equally. APAP, when it's been studied, and this has been done quite a bit, compared to CPAP in terms of adherence and patient preference, there does not appear to be an adherence advantage of APAP over CPAP. There appears to be a patient preference of APAP over CPAP. And there's a reduction in average pressure delivered with APAP over CPAP, which makes sense. So that I use APAP because it's practical, first. Secondly, I use APAP quite a bit because it gives me more data when the patients come back to see me. Where most CPAP devices report only hours of adherence, the APAP devices report hours of adherence, leak, residual sleep apnea numbers. So it's a much more robust data set that I can use to educate and guide my patients, because I see that as part of my role in the clinic, is to educate the patients about how they're doing and to be as precise as possible in terms of my recommendations to them.
No difference in adherence, is that correct?
Correct.
Dr. Gard.
Because CPAP is downright unpleasant.
MT.
Depends.
My question is in relation to the first question. So, if there is a You showed us some data on the questionnaire, which had a very good correlation with polysomnography. So how sensitive and specific is just the questionnaire in terms of predicting sleep apnea? Because if it's quite accurate and if you can generate data around that, then maybe on the more severe spectrum, we can eliminate the need of sleep study.
Yeah, the questionnaires for diagnosing sleep apnea, most of the questionnaires I showed you were for symptoms. The only one I really showed, and I didn't go into it as a diagnostic tool, was the stop bang. So for diagnosing sleep apnea, we have probably 10 different questionnaires that can be used to predict, pretest prediction of sleep apnea presence. And the stop bang is the best because it's the only one has a correlation with sleep apnea severity. So all of them are fairly sensitive, but not very specific for sleep apnea. The stop bang is reasonably sensitive and specific, and also helps separate mild, moderate, and severe with some accuracy. So I personally think that it's kind of like I like to tell this little story. It's like the stethoscope, right? The stethoscope is this great tool, but the single most important part of the stethoscope is the part between the earpieces. And so if you are well trained and you've studied the topic, you're going to be able to diagnose sleep apnea and adjust your therapy and know what to advise your patients very easily. And the only benefit really of doing some objective measure is to exclude other disorders, and also to some extent for risk stratification. Remember, mild obstructive sleep apnea has no adverse health risk. So if you're symptomatic and have mild obstructive sleep apnea, I'm going to tell you you should be treated for symptom relief. And I'm not going to get on you if your treatment isn't above the threshold at which cardiovascular risk is reduced. On the other hand, if you have severe sleep apnea and have symptoms, or even if you don't have symptoms, I'm going to recommend you be treated for health outcomes. And I'm going to get all over you if your treatment numbers fall below the threshold at which we see benefits.
So I think
Dr. Donna?
What's the role of nocturnal oxygen for patients who cannot afford study or the device?
Well, they have to pay for the nocturnal oxygen. They're not going to get that for free either. And that's about a $700 item for a concentrator. You know, the problem with nocturnal oxygen is that when you have upper airway obstruction, right, if you close the throat, the oxygen doesn't get to the lungs. And it does nothing about the increased interthoracic pressure swings that occur when you have an obstructive apnea and that create, vascular stress. So as a general rule, we reserve supplemental oxygen in sleep apnea patients to those who are hypoxic and have obstructive sleep apnea where the hypoxia persists after controlling the obstructive sleep apneas. So as it was back in 1989 when I got into this business, it hasn't changed much today. There's a small role, there's some benefit to it, but as a general rule, we reserve it for unique cases. And the health plans are all creating barriers for sleep apnea patients to be treated solely with sleep apnea.
Dr. Chediak, thank you very much. That was excellent.
My pleasure.